Welcome, everybody. Hello to you all. Good morning, good afternoon, good evening to you, wherever you're joining us from. We're so happy that you could join us today. My name is Soumya Alva, and I'm the Senior MEL Director for the USAID-funded Momentum Knowledge Accelerator, and also a Senior Research Monitoring Evaluation Advisor with JSI. The topic of today's webinar is Metrics That Matter, Conceptualizing and Measuring Person-Centered Care and Experiences of Care for More Responsive Primary Healthcare. So as you all know, achieving universal health coverage depends on strong primary healthcare systems. High-quality primary healthcare takes into consideration people's needs and experiences within the health system and in society more broadly. This webinar will discuss advances and lessons learned in measuring person-centered care and experiences of care within efforts to improve the quality and delivery of primary healthcare services across JSI's program areas. We are excited to share this work, as well as discuss important questions related to the measurement of these topics, which have become all the more important in conversations around quality of services provided. First, we'll have an overview of conceptualizing and measuring these concepts by Kate Gilroy, who's a Senior Child Health and Measurement Evaluation and Learning Technical Advisor with USAID Momentum Knowledge Accelerator and JSI. We'll then have 3 lightning talks highlighting measurement of experience of care or person-centered care across 3 different technical areas: immunization, child health, and HIV. These presentations will be by Lisa Oot, who's a Senior Technical Officer for Immunization, working on the Service Experience Project funded by the Task Force for Global Health with support from CDC and JSI. We also have Latana Chantala, who works with the USAID Laos Maternal Child Health and Nutrition Program. And finally, Jessica Posner, who leads the person-centered care portfolio at JSI. We'll then open the floor for questions and discussion. We know that some of you may have experience with measurement as well, so we look forward to your comments and experiences, as well as any questions you may have. So before we get started, I just wanted to go over some housekeeping points. If you haven't done so already, please introduce yourself in the chat. This webinar will be recorded, and after the webinar, we'll share the recording with all the participants. And finally, throughout the webinar, you can ask questions. We have a Q&A function within Zoom. Please include your questions there. We will be collating these questions and do our best to address them by the end of the webinar. And please add any other comments in the chat. I'm going to now turn things over to my colleague, Kate Gilroy, to start with the framing of the concepts of person-centered care and experience of care. Over to you, Kate.
Great, thanks so much, Soumya. So good morning, good afternoon, good evening, everyone. Next slide. Thought we would start out very simply. Some of you may be very familiar, but what is person-centered care? Because, if we're talking about measuring things, we like to define things or start with that. So it's really individuals, families, and communities are served by trusted and responsive health systems and actively participate in their healthcare with the support they need to make those decisions. And then on the other side, it's health systems are organized and responsive to individual, family, and communities' comprehensive need and respect their values, perspectives, and preferences, and provide supportive working environments for health workers and facilitate active participation and foster this collaboration between the health system and health providers and the people that are using the services. And to note that within the WHO people-centered framework, it also includes attention to the health of people in their communities and their crucial role in shaping health policy and health services. In my experience, sometimes person-centered, people-centered, patient-centered, or even family-centered care is sometimes used interchangeably and sometimes used to mean certain aspects of this overall vision. And so, the terminology can get a bit tricky. And I just wanted to pause here and say person-centered care is obviously important from a human rights perspective, but also important because for the accountability of the health systems, satisfaction both with the individuals, families, and communities, and health workers within the health system, and certainly for health and clinical outcomes. Next slide. So what is experience of care? So it's really, experience of care is the range of positive or negative interactions shaped by multiple factors experienced by people and their families across the continuum of healthcare. So it really is this intersection represented kind of in the light blue bar there, of how people and the health services are interacting. And so it can be anything from, say, physical infrastructure, such as the cleanliness of exam rooms or the toilets, all the way to interpersonal interactions with health workers and care providers. And are they treating people with respect and empathy? And so experience of care is really a key vital aspect of quality of care, but it's also important to ensure that people are returning to access and use services, because if you have a negative experience, you or your family or community are less likely to use services in the future. Next slide. So just to say, over the last decade, there have been calls for integrated people-centered primary health care, and in the context of universal health coverage. So the integrated people-centered health services framework was released at the World Health Assembly in 2016, and then more recently, universal called out in universal health coverage. And you'll see on the right-hand side, the WHO primary healthcare components and framework released in 2020 really have empowered people and communities, multi-sectorial action, and these integrated health services, all serving the health and well-being of people. So very much that people-centered lens. Next slide. So on this slide, you will see the WHO primary healthcare monitoring and measurement framework. It's very linear. We in the measurement world like that linear log frame. And just wanted to kind of call out, walk you through this and talk about why person-centered care and experience of care may be important within these different kind of aspects of measurement and monitoring. So in the light blue boxes on the left-hand side, you'll see structures such as governance, adjustment to population needs, financing. And this is really, are the systems and structures designed and supportive of that person-centered care lens? Are there adequate resources to enact that or to support that vision? And then next you'll get to inputs. And so these are things, physical infrastructure, for example, are facilities structured so they can, are they designed for all people? Are there, accommodations for people with special needs, for children? Health workforce is really, in person-centered care should be the biggest box. And it's really, are healthcare workers supported to provide empathetic, supportive care? And also, are they themselves supported, and what are their experiences? And even things like medicines or health information products come into this. For example, are there pediatric formulations for young children? Or are health information and digital systems designed in a way that they can ensure coordination and continuity between space and place and health services for a single patient? And then moving on to kind of the service delivery and I guess turquoise boxes, you'll see, these are more obvious places where person-centered care and experience of care come in. Are the services designed to meet people's needs? Are they organized and delivered in an accessible and affordable way? Or are they difficult and inefficient to access? So those things come in. And as I mentioned, in that lower box in quality of care, really this person-centeredness and experience of care is part and parcel. And you'll see aspects of experience of care and person-centeredness called out specifically as far as accessibility, continuity, comprehensiveness, and coordination, timely access, all called out within that quality of care box. And then finally, all the way in the navy, all the way over in impact in this framework, health system responsiveness is actually included as an impact. Next slide. So over the last year, so my colleagues at JSI have developed a conceptual framework for how JSI implements person-centered care and really foundational to our work. And at the center, you'll see is really people's safety and dignity, culture and identity, voice and choice, empathy and collaboration, and trust and transparency. And you'll see in the concentric circles, this is across all areas of health programming. So from the individual and family level in that red circle, all the way out to the navy circle in society and environment. And you'll see some familiar kind of interventions and levers and structures that are necessary to achieve this vision on the outside as far as leadership and governance, supporting the workforce environment and development, access and experience design, good service design and delivery, the policy and financing to achieve this vision. And then finally, monitoring, learning, and accountability. And I should note, this isn't just, for us who metrics folks, it's also meaningful routine engagement with community stakeholders and the use of their feedback for accountability and adaptation in the health systems. Next slide. So hopefully by now you're somewhat convinced, if you weren't before, that these are important concepts and probably important to measure, and that these getting better metrics, measurement, and methods for for patient-centered care and experience of care are essential, and are essential to. Can you guys see? Is that are essential for setting baselines, targeting interventions, targeting is this better now? Setting baselines and evaluating progress over time. And so apologies for the technical difficulties. I'm getting pinged. Hopefully folks can hear me now with my big purple headphones. Apologies. And so, these are all essential, but it's really complicated. As we saw in the PHC log frame, some of these things go from inputs all the way to outcomes and impact. The concepts and domains can overlap and differ by service area. For example, what is needed for a positive experience of pediatric services is quite different for a chronic infectious illness. These are complex constructs like trust, respect, and values, and they don't have simple yes, no answers. It's not like stock is available on the day of the visit. They're very complex and need multiple measures to try to get at them. And then finally, people's expectations influence all of this and should be taken into consideration. So the right answer is different in different contexts as far as, for example, if in some places, if an adolescent is receiving health services, they should be accompanied by their family, and that is considered person-centered. In other places, that might be considered a lack of confidentiality and privacy if the whole family was allowed to come along for those services. So overall, measurement is context-specific and requires adaptation for different settings and different health services. Next slide. So kind of how do we advance the measurement of person-centered care and experience of care? Usually what we do is we start with what is known or has already been done and what are the key concepts and domains to be measured as kind of a first step. And we'll be hearing from our colleague Lisa Oot for immunization service experience, where this is kind of a newer concept, and she'll be talking about kind of what's been done as before, what are the concepts and conceptual frameworks. And after that step, we usually move to how do we measure these concepts and domains as far as tools and methods, and are the measures feasible and valid? And we'll be hearing from our colleague in Lao about the pediatric experience of care, testing of tools and methods and validation. And finally, after all those sorts of things, we say, can these measures be used elsewhere? Can we disseminate and adapt them, for other contexts, and maybe even get included in a review of the next big thing in metrics? And our colleague Jessica will be presenting on the HIV person-centered assessment tool, where they've gone through kind of all these steps. And with that, And apologies for the technical difficulties. I'm going to turn it over to our colleague Lisa Oot to talk about immunization service experience.
Great. Thanks, Kate. Okay. Next slide, please. So I will be sharing with you all today work that we've done on measuring the role service experience plays in reaching zero dose and under-immunized children. Next slide. So I do want to start with an overview of how we define service experience within the immunization context. We've developed the framework that you see on the right, which focuses on 4 different categories: health system, health facility, health worker, and client, and then community domains. In total, we have 14 domains within the framework. Within immunization service experience, or SE, we define this as the factors within and beyond the interactions between a health worker and an immunization client, which influence the delivery and experience of the immunization service. In addition, I want to emphasize that many of these domains are interrelated and cross-cutting at the individual, the facility, the community, and the systems level. And it's critical to note that these issues can affect either the client or the health worker. Next slide. Now that I've explained a little bit about how we think about service experience within immunization, I want to spend today focusing on one of the major global priorities right now, which is reaching zero-dose children. Those are children who have not received a single vaccine, and under-immunized children, children who have yet to complete their vaccination series. So when we think about strategies to reach these communities, it's imperative that we think about the role service experience plays, both from the caregiver and the health worker perspectives. However, we have limited information right now on SE-specific interventions for zero-dose and under-immunized children and how those interventions are being measured. So we've set out to examine this further and to ask 2 specific questions. What SE interventions exist currently that are focused on reaching zero-dose and under-immunized children? And then what mechanisms or data collection tools exist to measure and monitor immunization service experience for zero-dose and under-immunized children? Next slide. So to answer these questions, we conducted a non-systematic literature review looking at both peer review and gray literature, which focused on lower middle income countries. 43 articles met our inclusion criteria from across 35 countries and 5 geographies. What we found was that the majority of the SE interventions focused specifically on community engagement and health service delivery. In looking at the prevalence and types of tools being used, we found that there was a broad range, including the Strengthening Immunization Service Experience Guide, the Behavioral and Social Drivers, or BES toolkit, as well as health facility and community assessments. The whole list is there. I won't read them all out, but we did find quite a number of tools that were being utilized. Next slide, please. So how are interventions being measured? So now that we have a better understanding of what the interventions are, we wanted to look more specifically about how they're being measured. And so what we learned was that the majority of the studies included in our literature review use quasi-experimental pre- and post-evaluations of immunization coverage. So that was the main metric being used. We learned that service experience related measurement is happening largely through pilot projects. We're not seeing SE data used regularly or systematically in routine monitoring and planning. We found that the majority of service experience interventions focus on community-related interventions, health worker empowerment, and then integration of immunization services with other packages. Notably absent were interventions that focused on workplace community and that specific domain within the service experience framework. Next slide. So what have we learned and what gaps still exist? So the literature review helped to expand our understanding of SE interventions and measurement. And we learned that the majority of SE interventions are focused on community engagement and health service delivery, particularly in rural settings. This means that the measurement of SE interventions in non-rural, i.e. fragile or urban, we need to expand documentation and learning and measurement around that. We also found that immunization coverage is the key outcome measure used, despite coverage often being a difficult metric to use. And we do suggest to expand the use of standardized process indicators to help with this. We also found that we're not gathering evidence on the changes in coverage among zero dose versus non-zero dose populations, and this is a gap that we should be exploring further. We also learned that not all SE domains are implemented with equal frequency. As I mentioned before, workplace community is notably underrepresented. We're not looking at how individual attitudes and interpersonal relationships between health workers, team dynamics, collaboration, how this continues to work, or job stress, about motivation. We're not seeing a lot of work around that, and certainly almost no measurement. So no study described actual efforts to scale interventions beyond making that as a recommendation. So again, we're seeing lots of pilot projects. We did find a broad range and options of tools, indicators, and methods, but it's not being used routinely in country monitoring, planning, or for continuous quality improvement like we'd like to see it. Lastly, we do recognize that a standardized and validated set of SE indicators is needed for immunization, and this is something as a global community we want to be working towards. So that's what I have. I am now going to pass to my colleague Na, who is going to share his work. Over to you.
Thank you, Lisa. Good morning. My name is Latana, and I am a research advisor for the USAID Laos Maternal Child Health and Nutrition Program. I will present our cognitive testing experience of pediatric care, which co-implemented with Momentums and Knowledge Accelerator. So next slide. So the PEC frameworks are an important contributor to ending the preventable newborn and child death by 2030. So it's ensuring the quality of care in service delivery. There has been less focus on the quality of the pediatric care. To address this, Momentum Knowledge Accelerator undertook the scoping review that took at the theory, frameworks, metric, and tool for the pediatric experience of care. So a comprehensive framework for the pediatric experience of care seen here is first then the develop. The framework has 2 primary domains and 7 subdomains. The first domain is interpersonal domain, which includes the 3 subdomains. One is effective communication and meaningful participation. 2 is respects the protection and fulfillment of the child rights. 3 is emotional and psychological support. For the second domain is the health system domain, which includes the 4 subdomains. One is the essential child and adolescents friendly resources, components motivated, empathic human resources, and 3 is the policy and organizational process, and 4th, safety and harm reduction. To measure the domains and subdomains outlined in the framework, the comprehensive tool was developed. The next step was to complete the cognitive testing exercise tool. Next slide. So the next slide is the PEC tool and process. We use the 2 tools in this testing exercise. The first one is the caregiver tool to learn about their quality of care experience. These tools include the 55 close-ended questions with yes, no, or Likert scale response option. It also includes the 7 open-ended questions about their experience. Second was the health worker interview guide to learn more about the context and experience from the provider perspective. This tool includes the 10 open-ended questions. So we first pilot test the tool in Vientiane capital in April with the male and female caregiver of the children under 5 years old, who has the visit facility for a sick and well child. The tool was then revised before data collection, which took place in the two district in Udomsai province in May 2023. So we used the interactive testing process where after a round of the interview was completed, we revised the tool and then test the revised tool with the next batch of the caregiver. This testing process involved reading each question as written for the response, and then prompting for clarity and relevance using the question identified here. The tool was finalized after 4 rounds of the revision during this testing period. The final caregiver tool includes 8 sociographic questions, 9 questions about the type of business of the facility used, and 64 survey questions that cover all the domain, subdomain from the framework. So the next slide. So the next slide, I will talk about the challenge and consideration. I will highlight a few of the main findings. The first, there are often social or cultural structure attached to the Laos word. For one example is the word respect. One example is the respect in Laos. Social interaction have an implied hierarchy. This hierarchy would be defined by age, gender, professional standing, for example. So if the client are asked if the health worker was respectful, they will usually say yes, because they should respect the health worker position. Instead of found, it was better to ask about specific action, like being treated with kindness or being listened to well. Second, it is important to understand how translation may shift the meaning of the words or how a word is interpreted. An example of this, feeling versus thinking. Expressing or demonstrating strong emotion is rarely done in public in Laos culture and is often considered inappropriate. It is more appropriate to ask about one's opinion instead of how one feels. So using the word think was better. Third, abstract concepts do not work well in Laos language. One example is enough, as it depends on the personal perception. Instead of we use concrete or literal phrase, such as asking, did someone walk into the room during our consultation? Our next step are that we recently implemented the tool as part of the health facility assessment across our 5-program province. And we are in the process of developing a scale that will reflect the domain and subdomains based on the findings. So the next presentation, I will hand over to my colleagues, Jessica. Thank you.
All right, thank you. That was a great presentation. As I'm Jessica Posner, and I'm really pleased to be here to talk a little bit about JSI's HIV person-centered care assessment tool. That is a mouthful, so I will refer to it as the PCAT for the rest of the presentation. If we go to the next slide, I won't spend too much time underscoring the importance of person-centered care. I think if you're on this call, and as my colleagues did a really good job of underscoring why we're here and why we think person-centered care and measurement in this space is important. I do, however, for the infectious disease space, just want to underscore the role that stigma and comorbidities play as challenges in delivering person-centered care. Also want to tip my proverbial hat to the community of people living with HIV and TB, because they have played such an important role advocating, demanding, providing person-centered care in this space. If you go to the next slide, Dakota. Great. Okay, so in 2020, before COVID, person-centered care was certainly a term being used in this space. And so we wanted to dig deeper into what it meant, but there really wasn't a classification system or a really strong set of definitions and what sort of counted, if you will, as person-centered care interventions. And so we did a systematic review, which we can share with you, where we looked at person-centered care interventions and where possible, where they were linked to outcomes. And from that, we developed a framework. And that framework was quite useful for us with our sort of implementer program design hat on, but it still didn't have enough teeth. It wasn't actionable enough for those who work at the facility level, who we really see as one of the main stakeholders in PCC service provision. And so we developed a tool, I'll describe it in a moment, but this tool took what we learned from the systematic review, and we did extensive consultation and refinement by reaching out to our many PEPFAR service delivery and technical assistance programs, and then also making use of our wide network of experts in this space. And then where the rubber really hit the road was conducting a pilot in Ghana. I'll describe that in a bit, but big thank you to the Ghana Health Services Western region for helping us make that possible. And then we're right now just wrapping up a larger sort of pilot phase 2, if you will, in Zambia, where we're also looking at the scores in relation to their clinical outcomes. Go to the next slide. So here's the basic framework. You'll see those 3 domains: staffing, service provision, and direct client support. And then within those subdomains, and then there's 4 subdomains per domain. And the magic really happens within the subdomain. There are usually 3 to 5 performance expectations that are per subdomain. Teams answer these performance expectations. They get based on what they answer, they get a different weight. And then those scores roll up into a domain, so subdomain score, and then eventually a domain score. So very similar to those of us who have used various performance capacity assessment tools. So if you go to the next slide, just really want to highlight that the scores themselves are not really meant to stand alone. They're really there to help facilities prioritize and identify strengths, identify weaknesses, and eventually, really the end goal is an action plan with people really choosing and thinking through how to better deliver person-centered care in specific areas. You go to the next slide. So as you'll see here, we did a pilot study in Ghana in 5 facilities, and there were clear trends. Staffing was consistently the highest, that red bubble, and client support the lowest, that dark blue bubble at the bottom of the curve. Interestingly, it's not the same trend we're seeing in Zambia, so we're interested to see what story there is behind that. But we also spoke to clients to make sure that the tool was reflected what they wanted to know about, what they wanted to get in person-centered care. And we also talked to the facility staff who participated in this tool to make sure that this was something that they could see using in the future. Next slide. So on this slide, you'll see a number of ideas that we have for future uses of the PCAT. But I will just highlight that one thing we're really mulling over as a team is related to the role of above site, or that health system level, and below site, the community level, to use PEPFAR term. Just the role that the health facility level and the community sort of play in really the delivery or service provision of person-centered care, and how we can better reflect those nuances and in this tool that is indeed designed for the facility level. Last slide. Just to say that, and I think this slide is not reflective just of my presentation, but of all of us who presented today, just to really underscore the role that measurement plays in providing an evidence base and really accountability mechanism for delivering person-centered care. And I think just a big thank you to all of you on this call who are also invested and in moving that forward. Thanks so much, and back over to you, Soumya.
Thank you, Jessica. Thanks to all of you, to Lisa, Nana, and Jessica for that quick overview, and 3 great examples cutting across different technical areas: immunization service experience, some steps in the process of developing a pediatric experience of care scale and testing it in Laos, and the implementation of the HIV PCAT tool in a couple of countries. So I see a lot of interesting conversations in the chat and a few questions as well. Before we go on to the questions in the chat, in the Q&A, I wanted to pose a few questions to the presenters really quickly, and we'll go in the order of the presentations. And in the meantime, please do continue to put your questions in the Q&A. So as you all know, all participants are muted, so please do put your questions in the Q&A. So first question to Lisa. What's unique about measuring immunization service experience?
Yeah, thanks, Soumya. Great question. So within immunization, we continue to see routine immunization expanding, new vaccines. For example, malaria vaccine has been added. And so this now means that caregivers, often the mother, may need to visit the health facility up to 8 times in the first year of life. So this provides quite a bit of opportunity for there to be interaction and between the health worker and the mother as well, and or broader caregivers. But it also means that we have to really have the full picture of how we measure the factors that influence a health worker's ability to provide high quality care. Does she have the vaccine? Is it kept cold and stored correctly? Does she have the skills to communicate effectively about vaccination? Is there a comfortable place to provide the vaccine? Is she able to give the right information to her clients? And so within immunization, we've been very focused on coverage as our main indicator, but I really want to encourage us and use this platform as an opportunity to really emphasize needing to capture and understand more of these broader process indicators and how we should be looking at measuring that. And that's part of what I want to advocate within immunization. We also want to make sure that we're looking at the shift within immunization, at looking across life course and how to ensure high quality care to a really broad range of clients and stakeholders. We need to cater and look at how we deliver those services to pregnant women, parents with infants, parents with adolescent children, adolescents themselves, older populations with chronic disease. And we still have a ways to go in terms of really thinking about how we measure and monitor service experience, what that means for these individual populations across their lifespan and as people age. So it's an ongoing process. And I really do think that we need to have more forums like this, where we're able to talk across cutting areas, triangulate data, and learn from each other. Because I think I saw in the chat, there's some really great questions around, are there similar domains? How do we really think about using data in that way? So thanks, Soumya.
Yeah, thanks, Lisa. That's really helpful. I'm going to pass this on to Na from Laos and talk a little bit about the cognitive testing and the work you've done in Laos. So given your experience fielding the pediatric experience of care tool in Laos, which is happening right now, do you see any changes that may be needed in other country contexts so the domains of this framework, of the pediatric experience of care framework, are captured appropriately?
Thank you, Soumya. Yes, I think so, especially in the country with the multiple ethnic groups who may have the both share and distinct culture, tradition, and experiences. Based on our experience, how questions are interpreted depend on the perspective of the respondent, which in turn is conditioned by their culture, context, and lived experience. In our case, we found that the question asking about feeling, emotion, or more abstract, the comments seem to be particularly susceptible to different interpretation than the question in intent. This likely affects question on the two asking about respect or communication between the client and health worker, why it may not be possible to complete the full cognitive testing exercise with every tool developed. Our experience demonstrates the value of at least identifying testing of the type of the question within the cultural context that may be more susceptible to different interpretation. This can be also help ensure the accuracy of the measurement. Thank you.
Thanks, Na. And one question to Jessica about your work with the PCAT. What do you see are the remaining gaps and work that needs to be done in the area of person-centered care, specifically for HIV, based on your perspective?
Thanks for that question. Well, gosh, there's a lot. But maybe I'll expand a bit more on the point I was trying to hammer home in my next steps slide, which is really that, yes, person-centered care particularly in the infectious disease space is sort of provided or is happening at the facility. But when we looked at the action plans and the scores from our various pilots, we were seeing that so many things are not in the control of the facility staff, and we don't want to demoralize people. So just really trying to get our heads around how the tool could better reflect and empower people when these actions like advocating for staff or funding or tools for X, Y, and Z, so above site things, or particularly for the direct client support domain, working with communities, how we can sort of collectively come together to maybe do to complete the tool, or think about how the tool can better address these power and directionality issues.
Thanks, Jessica. I'm going to go to the questions in the Q&A. And I see that there's a lot of chatter as well. And thanks to all of you who've been responding to some of the questions that have come up in the chat as well. So do keep that conversation going. But I'm going to go to some of the questions in the Q&A. First was from Christina Granger. Do we have data that constructs and domains indeed do vary across services? I'm curious to understand this more. Why would that be, and what do we know about that? So I want to throw it open to any of the presenters. And if there's anything you want to add in the chat, please feel free to do so.
Hi, Samia. I was starting to answer that in the chat. I think WHO, I may have misspoken. A lot of the domains are similar as far as respect or dignity and those sorts of things. But sometimes the subdomains and how you measure them are different, and there may be differences in some of the service areas depending. And actually, I think some folks on the call and the WHO is actually working on mapping this across the RMNCH continuum of care plus aging and primary health care to look at those, the similarities and differences in the kinds of constructs and domains that are important, mostly for patient-reported experience metrics. And I'm not as sure about across the patient-centered care continuum, which is even broader than experience of care. But there is work going on to see how to compare and contrast those across service areas, because some are very similar and some are a little bit different. Over.
Thanks, Kate. I'm going to go on to other questions that we have. Another one says, I'd like to hear the panelists' thoughts on the earlier observations on how expectations of care influence patients' evaluation of their experience of care. What have you found that's being done to address or measure this component? How important does this component seem among the myriad factors affecting experience of care? I'm not sure who wants to answer this.
I can
Jessica, Lisa, go ahead.
I can just start and say from immunization, it's an important part of our service experience framework, where we do have a domain that's focused both on perceptions and expectations of care. It's difficult to measure. And I was actually just typing back to Cola's question in the chat box, but what we commonly find is that in order to really get people's perceptions on quality of care, we're using client exit interviews or community boxes, and they have real limitations in terms of the type of feedback that is provided, and then also how any of that feedback is then internalized into program improvements. We also see that it depends, but there can be pretty low expectations of care. Sometimes people just expect, I'm going to sit here for 2 hours. And so when you ask them a question about that, they expected to sit for 2 hours. They sat for 2 hours. So they said, yep, it was great. So I think there's a lot more that we need to be looking at there, and to be thinking about how do we better measure this. I don't think we're, at least within immunization, we're not quite there yet. I don't know, Jessica or Na, if you want to add. Over to you.
Does anyone else want to add to this? Otherwise, we have several other questions we need to get to. Okay, I'm going to go on to the next question that we have. If there are any other comments related to this question, please do put it in the chat. So it's a question from Richard Holman Matanta. Do we have any experience in integrating the routine health information systems such as DHIS2 or any other tools to routinely monitor and evaluate the quality of person-centered care? I mean, this is a question that we are all grappling with. So any thoughts on anything in routine data that could answer these questions?
I'm not exactly answering the question. We do have performance expectations around if the DHIS2 that people are using at that facility level can provide data to indeed enhance person-centered care. So it's kind of the other way around. So the tool does indeed take into account how important DHIS2 or whatever system is being used, but in terms of how to do it the other way and make sure that our routine systems are kind of monitoring person-centered care service provision, I'm not sure we're there yet, at least in the infectious disease space. We haven't come up with sufficient proxies.
I think that's an ongoing challenge that we have, and so we rely on facility assessments and client exit interviews to get this information. Okay, the next one we're going to go to on HIV again. Who's responsible for measurement and subsequent action planning? Is it the facility level, district level, or NGO led? And how can this approach be sustained? And are tools such as the PCAT fashioned in a bottom-up or top-down to manage health outcomes? How are the field workers, frontline workers involved in the design process? Jessica?
Ooh, that was a lot of questions. Okay, let me see if I can if I can answer. So at the moment, we've only done this in a facilitated manner. So we trained a facilitator to go in and work with and administer the PCAT, and then work the teams through the action planning process. So that and that has been done either by at present JSI staff or in consultation with the Ghana Health Services in that country. We are really excited to have a meeting next week with the Ghana Health Services, who are really looking at how to adopt this as a quality improvement tool. And so that is by far, like, that's my dream outcome, that a system would adopt it and have an approach to regularly administering the tool. So that is sort of, but right now, the tool is available. I imagine a lot of more NGOs would sort of use this, but it's available, and it is not a heavy lift. It's not a complicated tool. I'm not sure I understand the bottom up or top down question, but I would say that we really consulted a lot of frontline workers in the designing of the tool, in the refinement of the tool, and then really incorporated their feedback through each pilot to improve upon the tool.
Thank you, Jessica. I see the next question, which is on measuring person-centered care with SRH service provision to adolescents and youth. These are key populations who link to PEDS, immunizations, and HIV, which is what we covered now. We didn't touch upon this in this webinar, but I do want to talk about some work that we're doing through a Momentum Knowledge Accelerator. We're in the process of putting together a landscape review of ways in which measures of experience of care are being measured across RMNCH, including family planning. And honestly, in LMICs, we're finding very little out there. So we're drawing upon pieces of work, measurement aspects in across the developed world. And the next step, I think, would be to develop some kind of a framework and try and see how we can better measure this in the LMIC context. So please look out for this landscape review, which should come out in the next couple of months or so to get this conversation going. The next question we have on mentioning on community engagement interventions, trying to enhance service experience. This is something that you mentioned, Lisa. What's the theory of change? How and why would you community engagement enhance service experience? I think you put that in the chat already. So I'm going to go past that. Lisa, do you have anything else to add before I go to the next one? I think you answered this in the chat already.
I did answer. And I just to say that it's such a critical part because it's really where we really build those strong linkages between the communities and the health workers, and that there's really this co-creation process around helping to design and improve better services so they're better meeting the needs of that population. That's also why we want to do this really tailored, right? So at the local health facility level, what you're designing with that community may be very different from what you're doing even 20 kilometers away. So yep, just to say that.
Yep, thanks. We also have a question from Melanie on PCC frameworks and metrics. And thank you, Melanie. And you talk about AI and sentiment analysis of the customer base that companies do and how we could apply it to this context. I must say, I don't know if any of you have answers to this from our experience. We haven't gotten there yet. So it's just something to think about related to AI. But if anybody has responses to this question that came up in the chat, please do respond in the chat as well. Any of our panelists want to say anything about AI? If you've thought about this some? I don't think we're there yet, but it's something to keep in mind and think about to see how we could use this in our field. Okay, question from YJ. There are different service programs that have developed PCC measurement tools in the past several years. Any thoughts on how it might become feasible or useful to develop person-centered care tools for a broader PHC, not specific to services? When we think about similar data collection methods and limited resources, that question is important. If I understand this, this is like trying to develop a generic tool that can be used across different domains. Anybody wants to take this question on?
Yeah, I do believe, and I mean, this is not our work, but WHO within the primary healthcare framework is, at least for the patient-reported experience metrics, trying to develop a bit more kind of cross-cutting tool in measurement. And my understanding is these are being pilot tested in Ghana and maybe elsewhere currently, because the primary healthcare framework is relatively new. I mean, that monitoring framework was from 2022. And so there is work going on to try to get those cross-cutting domains. And again, like I said, there are some working groups at WHO also looking across those cross-cutting domains. And even for the SPA survey, the USAID supported SPA service provision assessment, I know there was work to try to kind of do some of the same measurement across different aspects and services as well. But sometimes, like I said at the top, that it can differ a little bit. So it is hard sometimes to get something that is pertinent to every single type of service area, because they are a bit different. Over.
Yeah, thanks, Kate. Another question on person-centered care being very critical in service provision, and there was a question on person-centered maternity care. Does anyone want to answer this?
I love that scale, and now we have used it in other work in lab that results forthcoming, and we're really excited about it. But yes, kind of started with what was out there. There's a maternity, there's a family planning one, and other sort of areas that had built out more robust metrics around the person-centered care in this person-centered care space that we certainly use to inform.
Thank you. And I see some other questions related to satisfaction that came up got answered in the chat. We have a number of questions out here. I'm going to take another one question, and then unfortunately we're going to have to wrap up, and we will send responses to these when we share the recording. So one more question. Since it involves commenting on accountability and quality of service delivery by providers, were the providers receptive to using the tool? What challenges came up? Jessica, I think this might be for you.
I lost the mute button. Yes, we did focus group discussions after doing that, and we really got really good feedback. It took about an hour. People felt like it was a sufficient lift. We really make sure that there's a wide group of people who work at the facility that touch all levels of the system. So that was a really important finding for us, and we published that. I think Sarah put results in the chat. And then similarly, we did a similar exercise with clients just to make sure, none of us are the people actually receiving the services, yet we're pronouncing on what's important about person-centered care. So we did really need to do a validation check with clients, which is a slightly different issue, but just to say that that also happened.
Thanks, Jessica. I am going to pose another question to you following this. Based on the data collected, did it change the delivery of programs? Do you have any examples?
Mm-hmm. That's a good point, and that is part of our longer term plan. Right now, we sort of stopped at the action planning stage. We do have all of the Ghana groups coming together in that meeting with the Ghana Health Services. So I'm really interested to see if things have moved forward in those identified action plans. And then the 30 facilities that we did this in Zambia are JSI supported facilities. And so we have plans to go back in a certain time, because that's really right. If things didn't move forward, that would, hamper the hamper the tool, certainly. So good question, and stay tuned.
Thank you, Jessica. There's a lot of chatter here, and unfortunately, we're not going to be able to answer all the questions, but we made a note of them, and any that did not get answered, so we can send responses when we share the recording. But thanks, everybody, for attending this webinar. It's been great to see such great attendance from all over the world, and I hope it's increased your understanding of this important topic. Thanks also for all the contributions in the chat. Some questions are questions we need to start thinking about a little bit more. So as you can see, we have a QR code here, and the recording and other resources. Links to the pages that we have on this topic will be shared. They're available online, and we will send this to you by email to all the participants as well. Thanks very much, and thanks again for participating in this webinar. Bye-bye.